Okay, good morning, and it's a real honour to be following on from other speakers this morning. As you'll see, my presentation at 1 or 2 points rest heavily on the amazing work they've done. The starting point for the Ear Foundation, who I'm representing today, has been a long project looking at trying to demonstrate the real cost of hearing loss. Basically, some of the reasons that Peter was just alluding to and that Paul alluded to at the beginning, which is within the health policy community and within social policy, the total underestimation of the consequences and impact of hearing loss and the consequences that has then in terms of public provision and support for hearing loss, not just in the UK, but a lot of the work we've done has been across Europe as well. And therefore we're essentially resting on the shoulders of the amazing work that's been done by the research community and the voluntary organisations and audiologists in doing that. So anything I'm going to present today is in the only parts that are actually original are those that relate to demonstrating the real cost. In terms of the actual audiological science, I'm very much resting on other colleagues in the room. We've had some of this laid out, so I'm not going to spend too long in the first part of my presentation on making the case even more for why hearing loss is a major issue. But if we just look globally, which hasn't been talked about too much, over 466 million adults experience disabling hearing loss. This number is still rising with a cost globally of over $750 billion. According to the World Health Organization. So across the world, an absolutely massive issue. As Peter said, within the UK, 11 million, 1 in 6, rising by 2035 to around 15.6 million people, which will be 1 in 5. So a major issue to be addressed. And as we know, very related to aging, as is dementia. For those over 70 years of age, hearing loss is the most common cause of years lived with disability, which therefore you would hope that you would see it reflected more in health strategies than you actually do, given the consequence on individuals. Dementia, as people have mentioned again, although the actual incidence may be less because of the ageing population, that is still nevertheless growing. Over 50 million people worldwide over 65 years of age diagnosed with dementia, and that number is expected to triple if we don't take any mediating action by 2050, just due basically to the rising number of older people. The cost of caring for those with dementia in 2015 on one estimate was over $820 billion. And 85% of those costs are related to family and social costs. And it's that relation to family and social costs that's crucial when you start to look at the costs of dementia and also the cost of hearing loss, which is one of the big kind of co-related issues relating to that. As people have said, so I won't go into this, we know that declines in hearing and cognitive function are both strongly associated with each other. So I won't go any more into the case that's already been laid out around that specifically. A number of studies have already been mentioned. The Lynn studies, hearing loss is also associated not only with the early risk of dementia, but accelerates the rate of cognitive decline. A number, as Paul was saying, almost a torrent of studies over recent years now beginning to show you that meta-analysis or longitudinal studies that there's an increased risk of incident dementia associated with hearing loss. So that association, if not the cause, has become incredibly strong. Over 60% of adults living with dementia will also have hearing impairment, and over 90% of adults living with dementia in aged care will have a hearing impairment. So when we get to that point of those living in care, there's almost a complete association between hearing loss and dementia, and therefore the need to address those two together. We know it causes poor functional ability compared to those that have no hearing loss or dementia. I won't go any more into the Lancet study and what it shows, that's already been ably covered, except to say I totally agree with the points that politically the Lancet study has led to a major shift in people's perception, not least because you get editorials like this that I'm showing on the screen now from the Lancet, which deliberately starts to make the link about more being done to raise the profile of disabling hearing loss, and the WHO resolution should serve as a catalyst for coordinated global movement encouraged at the country level involving healthcare professionals. And I think it's that crucial coming together of the recognition that actually addressing hearing loss could help address dementia. I remember in one study I saw even a 1% reduction in dementia correlates to a huge saving on social and health care costs. So this should be of fundamental interest to all health commissioners and planners in a way that currently is not, and that's the bit I kind of want to come to some extent. Moving on to the impact of hearing instruments, again, we've begun to have a whole plethora of studies that begin to show that there is an impact, and we've heard already this morning from Helena about that, and I think we're going to hear some more in a minute. And so just to kind of add to that, as well as Helena's study, the work by Deal found that there may the hearing impairment may be a risk factor for cognitive decline in older adults, and that hearing aid use could possibly reduce that risk. We've got other studies saying hearing aid use was associated with better cognition in large cross-sectional study of UK adults from Dawes. We've also had Monsor and Volta looking at the impact of cochlear implants on cognitive decline and finding that cochlear implants, even in the much older population, still have an impact on the rate of cognitive decline. And sorry, that shouldn't say one more studies, it should say many more studies are also showing similar results. I haven't got time to go into all of them now. So the challenge is that we think that early adoption of hearing technology may ensure continued ease of communication so as to prevent social isolation and increase of cognitive decline. It may be one of the best ways possible of supporting independence for longer and healthy living into older age. But as we've said already, there's a resistance to adoption of those hearing technologies, and one of the best ways of actually possibly addressing that could be hearing screening. But certainly in the UK we've had massive problems in actually convincing the UK Hearing Screening Committee of that, and one of their major reasons in not is consumer resistance to adopting hearing technology. Now I think the BIHIMA work shows actually that is fundamentally shifting at the moment, but we seem to be having to catch up with a perception that hearing instruments are not well used enough and not well recognised in being used enough. And we know there are issues around that, but I think that perception is perhaps stronger than the actual evidence now shows in relation to all of that. There are some challenges, not just around the acceptability of hearing interventions, but also if we're looking at screening around dementia, there's no standard screening process for dementia or cognitive ability in current audiology practice that's accepted across the whole world. And so I think the challenge that you were laying down around the audiology practice is the major issues there if we're to start to bring things together. Moreover, there are few interprofessional teams linking specialities in cognition, hearing and genitology. Audiologists have little experience or training in assessing and managing the hearing of those with dementia and cognitive decline. And so I think one of the big challenges, if we're therefore to get this right, is what we do about that. And we need a greater understanding in the health community that good hearing helps people stay connected, reduces loneliness, and supports health and well-being. And until that is established across the hearing community, we have some serious challenges. So that's the background about how we bring hearing loss and dementia together and the role of hearing instruments in doing that. What are the social costs and societal arguments around making that happen? So what's the cost of not addressing hearing loss and dementia for health planners and commissioners? Because it seems to me that is still the major challenge we've got, even if the science is now beginning to flow very much in favour of joining those two together, is how do we get that across and how do we persuade health commissioners to actually make that happen? One of the elephants in the room is money, and as I said, a lot of what the Ear Foundation work has been about is about the costs of not taking action to address hearing loss rather than the cost. And our whole basic thesis has been that we need to shift the conversation away from the cost of addressing it to the cost of not. And those are the 5 reports we've done on that so far, and the 6 on hearing loss and dementia will be coming out shortly. I'm just going to present a few of the key findings from this. There's a lot more in these reports. And they won't exactly match up with the Bridget Shields stuff that's just been produced because we're measuring slightly different things. So when we had a look at some of the key costs of not addressing hearing loss, we found 26 billion on the costs of reduced quality of life, 4 billion on the direct costs of lost earnings, not the indirect costs, but just the direct costs of lost earnings, 76 million in terms of extra GP visits, and 60 million in terms of the extra cost of social care. And obviously what's fundamental for this debate is the 60 million and the 76, but also what's bundled in a lot of that 26 billion costs of reduced quality of life, all the other additional costs that follow from that that Helena was putting up earlier in terms of impact on people's life and quality of life. We also looked at this in a different way, which is another great survey, is the British Household Survey, where you can go back and you can look at things like how often people use GPs and how often people use social care. And we went back to before the introduction in a mass market way of hearing instruments in the UK. And then we looked at how much people that had then used hearing instruments also use social care and visits to the GP compared to those that didn't, and found that those that had used those technologies over those years had reduced use of GP visits and social care, which amounted to a saving to the NHS of 92 million a year, or 1.5 billion from 1992 to 2009. And so that's a kind of different way of cutting into the whole issue, because a lot of times some of these economic studies get criticised for the way they hypothesise some of the costs. So this is a way of actually looking at real costs within the system from the introduction of hearing instruments to when they weren't being used, and what impact that has. We then looked at a different way across Europe, and looked at, again, a number of similar surveys across Europe and the use of social care and GP visits in different countries across Europe. Now, I know you won't be able to read the detail on that screen, because the only thing you really need to know is that the average additional cost per hearing impaired person is approximately £242 per annum, and the total healthcare bill for the EU 28 countries, which it still just about is, was approximately £15.6 billion due to the extra costs of accessing that health and social care. And what's really fascinating is the country that has the best adoption of hearing instruments is Denmark. And those with the best hearing care have the lowest costs on other care services. So we can prove absolutely, in a number of different ways, the interrelationship between those that have hearing loss and take no action on their hearing and the cost on the health system, versus when we can show that people do take action on their hearing, the costs on the health system reduce. And we've shown that in 3 completely different ways using completely different methodologies to show that that actually works. Just to pick up on some excellent work done by Action on Hearing Loss, they also looked at how, if you support people around social care and hearing loss, what the potential cost benefit is there, and found that for every £1 invested, there was a social value of £10, very precise, 34p. Let's just even say it was £10, as a ratio of 1 to 10 in terms of the cost benefit of actually providing support for people around their hearing care, the amount you're going to save by doing that. If that wasn't enough, a very good survey from France, the economic impact of hearing loss in France and developed countries, by Cochlear and colleagues, showed that for the French system, the greater take-up of hearing instruments would save money. Expenditure of 1.5 billion euros in provision would deliver savings of 1.7 billion euros in terms of healthcare expenditure. Basically, that providing everybody with a free hearing aid and them using it would save the French state over 200 million euros. That study was instrumental in persuading President Macron to change the French health system such that they're now moving over to a system of providing free hearing aids to most of the French population, I think starting from next year. I think the process started this year and coming in more next year, yeah, this year. Really interesting, he also found that there was a return on investment of €1 invested equals €10 saved, close to the same estimation that we did in our own research. And there, where I think it becomes then fundamentally important is if that's the savings around hearing loss, if you then apply the same methodology to dementia and dementia care, you get an amazing escalator effect in terms of the potential savings and cost-benefit savings. One very recent study by Brent looked at this, and on conservative estimates, found that the total benefits, mainly coming from the direct benefits, so you didn't even look at indirect benefits, were extremely large relative to the costs, with benefit cost ratios of over 30. What this means is for every pound or euro spent, you get a saving to the state in terms of care costs and health costs of 30 euros. So, if you're a health administrator, a planner, or a commissioner, there's probably very few places where you would be able to look at investments of that level, delivering that level of cost benefit. So, we need to change health policy from thinking like this, that the audiogram and the hearing loss and the dementia is a cost, to thinking of it as an opportunity to make massive savings across the health system. And that's essentially what we've been about. The problem is this, health commissioning. So in God we trust, everybody else bring data. You have to Mr. Spock-like focus. In looking at how you deploy this stuff within the health system, because health commissioners essentially don't believe you. And it's one of the great problems we still face in terms of hearing loss, is how we present this case to health commissioners in a way that they see the multiple comorbidities, one of which is hearing loss and dementia, and the potential savings that could occur if they address that rather than some of the other things they focus on within the health system. And this is the kind of attitude certainly you get in the UK in terms of all of this, which is that you're making the most effective use of the limited NHS pound, and even with the success Simon Stevens has had in getting the extra billions, it is still the core question: where can the NHS most spend its money so that it gets the most health benefit back? As you've seen from the economic case, I think we now have a fantastic case to make, especially when allied with dementia. It's how we then get that across in the health system when that is the attitude of clinical commissioners. Prove it to me. And you actually very worryingly had, admittedly this was in the middle of his battle with the Treasury to get the extra money, Simon Stevens saying that the NHS was not going to fund any new nice recommendations unless the NHS was specifically given the money to do it. And the two areas he focused on that would relate to was one, hearing loss, and the other was dementia. And those were the two he specifically mentioned. And that's from the report out of the Times. For the first time, Mr. Stevens said new guidance would not be implemented next year unless it was funding was agreed in advance. The decision threatens best practice advice to do next year on conditions from sight and hearing loss to arthritis and dementia care. And we're still struggling with some of the consequences of that decision at the moment. Peter mentioned the NHS plan. It only mentions hearing loss once, as far as I could find, which is actually in relation to the problems faced by people with learning disability, but was not mentioned as a core area in its own right. Even dementia, quite worryingly, gets mentioned quite a few times, but often in relation to other parts of the system, such as social care or mental health, or as a comorbidity along with other areas. As evidence-based commissioning becomes more common across all EU countries and certainly within the UK, we therefore need to look at how we represent this whole case around this in a way that's going to link into the system. In the UK, that means looking a lot more at key themes around how does it fit in with primary care, how does it fit in with social care, how does it fit in around care homes and the issues of screening for hearing loss and dementia in care homes, where does that fit in the whole concept of personalised care. And I think some of the things that have been said about technology and the amazing advances in hearing aid technology will mean an even more personalised care path for those that are adopting those hearing technologies. But there's a major challenge, I think, in how we do this in a system that even now with this evidence is not really addressing how hearing loss affects across all these comorbidities. As Helena said at the beginning, this isn't just about dementia, it's about mental health, it's about falls, it's about general cognition. So there's a whole number of areas where we need to look at how we address that argument. Peter mentioned the action plan. We have been working in the UK on a national action plan for hearing loss. It's not at the government's agenda, but it's the only formal thing we have in the UK that actually is a plan about what the system needs to be doing around that. So I think we still need to look at how we can reinvigorate that and use it. And indeed there are, as a result of that action plan, some what works guides. One of them actually produced in co-production with NHS England and Action on Hearing Loss and the Alliance on Hearing Loss on what works hearing loss and healthy ageing, which does have a whole section on dementia and did try to start to pull together and make some of the arguments around this. So in conclusion, what do we kind of need to make all of this happen? I think we need to change the conversation to the cost of not addressing hearing loss and dementia. It's a major opportunity in health policy because actually dementia is something the system really cares about. And if that means we ride on the coattails of that to some extent, I'm very happy to do that. I think a national screening programme for hearing loss is essential and we need to keep pushing away at that. But in the meantime, opportunistic screening programmes, especially around social care homes, especially in relation to other areas, sight loss being the most other obvious one, I think is a possible way forward. But those screening programmes need to be sensitive to the association between hearing loss, dementia and cognitive decline and not confuse them, which also happens. Targeted screening programmes for those in care homes or living in residential homes, I think it's really important, it's beginning to happen, and training for health and social care professionals in identifying and managing hearing loss for those at risk of dementia. I encourage you all, we can sort of pass the detail about this, what causes what, where and when. I think the overall picture is clear, and the more we can use hearing and dementia and the association between them to actually be the opportunists in this system rather than the pessimists or the optimists, and actually use this as a major opportunity to really drive forward the conversation about hearing loss and dementia and how we address them together, the better. Thank you.